Hi, I'm Amal Assa'ad. I'm an allergist immunologist at Cincinnati Children's Hospital Medical Center, and I am here to talk to you about oral food challenges, which are procedures that are conducted by physicians to confirm the diagnosis of food allergy or to remove the diagnosis of food allergy. I'll tell you the good things about them and the not good things about them. And I also will tell you about the FACE challenge, which is a challenge that's set up by FAIR to try and replace the food challenge with a simple test that could achieve the same outcome of determining whether there is a food allergy or not. Food allergy patients come as Caucasian, African American, Hispanic, or Asian. They come following a very strict diet, or they avoid the food so-so. They might have eczema or have baby soft skin. They might be ones who wheeze every night and have asthma or have the lungs of Bode Miller. They could be 5 months old, 5 years old, or 15 years old, or for that matter, 25, 30, or even 65-year-olds. They could have one food allergy or half a dozen of them. Sometimes they're very anxious. Sometimes they're very cool about it. They could be a handsome boy or a cute girl. At the end, patients with food allergy face a big challenge. I am Amal Assa'ad. I'm professor of pediatrics in the Division of Allergy and Immunology at Cincinnati Children's Hospital, and I'm the director of the Food Allergy Research and Education Fair Center of Excellence at Cincinnati Children's. Today, I'll talk to you about oral food challenges. Why are they done? How are they done? And what we can do about them to change that. So I always think of food allergy in a trio: the patient, the food, and the test. And by the test here, I mean the usual skin test that an allergist can do or blood tests. So patients come commonly actually where they have never eaten the food, but some who have never eaten the food were never tested to it. Some never ate the food, but the test is negative, and some never ate the food, but they had some tests and they were positive. Some patients come where they've eaten the food and had a reaction, but some would have tested negative, some would have tested positive, and some were never tested. So the patients who never ate the food, why does this happen? Because sometimes testing precedes the first ingestion and results are interpreted as positive. And this is a very usual scenario for peanuts. Sometimes the sibling has the food allergy, so the food is banned from the house. Usually, again, it's for peanuts or for cow milk, but can be also for eggs or other foods. Sometimes there is an ingestion which results in a convincing reaction, but many years ago. Sometimes there is a repeated ingestion, but food had been removed from the diet in the management of another atopic disorder like eczema, where patients are commonly tested to foods, they have lots of positive tests, and then all these foods are removed from their diet. Sometimes they've had repeated ingestion, but someone noted a possible reaction, so they removed the food from the diet. So let's take some examples of patients who had food challenges and who came in with possibly a food allergy. So this young lady is 13 years old now. She had one reaction in infancy when she was a year old, was given peanut butter on a cracker and did okay. A week later, they give her just the same amount again, but then had some facial swelling within minutes. They called the doctor, they drove to the office. In the office, they waited for half an hour. Eventually, after an hour, when she was seen, all her symptoms were gone. The blood tests to environmental allergens some were positive. And just to orient you, so this test, if it's less than 0.1, that means it's a negative test. Positive tests are anything above that. Her tests to tree nuts actually were all negative, but her test to peanut, which was repeated twice, was what I would call a low positive. So the question was, is she still allergic? So after discussion with the mother and father and the patient about what we're going to do, they decided to do an open food challenge. Whether open or double blind, they decided for an open one. So the child was very anxious about the challenge, but she was quite hopeful that she'll pass the challenge, meaning she'll be able to eat the food with no symptoms. At the first dose of 0.05 gram of peanut butter, which has 0.0125 milligrams of peanut protein, which is equal to, if you take a peanut and divide it into 3,000 pieces, this is one piece. She immediately complained of feeling that her throat is itching. She actually said her throat was bleeding. Her exam was normal, so we assured her. 15 minutes later, she had thoughts. After her symptoms resolved, she received the second serving of peanut butter. This was a bigger dose than the previous one, but slightly so. She tolerated it, but a few minutes later, we could see that her lip was starting to swell and she's getting bumps on her lip. Her face is turning red, and you can see here a close-up of her lip. Well, everything else remained stable. She was given a dose of Benadryl, the lip swelling and hives resolved, but she cried because she was disappointed that she's still allergic to peanuts. We monitored her in clinic for another 2 hours, which is common with food challenges. She had no further complaints. Parents were comfortable taking her home and to come back if she has any other concerns. And we discussed that she'll return in 1 year for evaluation, and they will continue strict peanut avoidance. Today, probably we would have considered putting her on oral immunotherapy. So what did we learn from the challenge? The outcome was contrary to expectation, but we answered several questions. Is she still allergic to peanuts? What might happen if she ingests peanuts? What is the minimum amount that will give her symptoms? Here's another patient who may or may not have eaten the food. This young child was previously tested because of eczema, had multiple foods as expected, avoids now a long list of essential foods: cow milk, eggs, wheat, fish, and peanut and tree nuts. She has a definitive history of ingestion or reactions was rather difficult to obtain. So she had had blood tests for environmental allergens, which again, at this young age, she's positive to many of them. So these are highly sensitized patients. But at 1 year of age, here are her multiple tests. At 2 years of age, looking at the eggs, which had gone down, we figured, well, maybe she would be able to tolerate eggs. And of course, we wouldn't have challenged her to peanuts because that test suggests that she would react. When she came to clinic, she had eczema, as expected, but she was playing and watching a video during the food challenge and doing fine until she got to a point where she was supposed to take 4 teaspoons of scrambled egg. She only took half of it and didn't want to take any more. And we noted that her eye had become red, as you can see here. So she had received about 5 teaspoons of the egg, but she had no other symptoms. But she had said, "Oh, my mouth hurts," but then denied it, which gives you an idea how difficult it is to do food challenges on children because they tell you things that you can't really interpret. Anyway, she was given the Benadryl. Her vital signs were normal, but after 30 minutes, she vomited once. Once she vomited, she was back to her baseline. She was interactive and everything was fine. So again, the outcome was a bit contrary to what we expected, but we got important information from the challenge, which is that she's allergic and needs to avoid eggs. She could tolerate a rather large amount, 5 teaspoons, before reacting. But we also thought her prognosis should be hopeful with a repeat challenge to eggs in the future. So another patient who has history of ingestion and reaction and needs to be confirmed. This patient is 17-month-old male who was seen again for follow-up of eczema. Eczema is improved, but the history is that he got stuffing in daycare on Thanksgiving and developed wheezing. They called 911, they got epinephrine, and when the mother got there at the same time as the paramedics, she describes redness, swollen lips, and difficulty breathing. He eventually was kept in the hospital for overnight. And a week ago, he got half a cup of milk by taking the cousin's sippy cup. He vomited 10 to 15 minutes. Then had hives on his forehead. So this child has a history that's very recent, suggests a food allergy, particularly to milk, so there is no need to do a food challenge here. But here's another one who was there for follow-up on food allergy to cow milk. His reaction had been 2 months ago. Grandmother had given him cow milk instead of soy by mistake. 15 minutes later, he coughed and vomited in the mother's car while driving to daycare. And so he was given Benadryl and had no further symptoms. They were really concerned because there's 3 kids in the family with several sippy cups. They were thinking there's always going to be a confusion. So they marked his cup with an orange tape. Anyway, here's his tests, and these are the tests involved to milk and the milk, various milk proteins. And again, they were low positive. He's also already allergic to dogs. So this child was given a drop of cow milk and he resisted it. He didn't really want to take it. The drop smeared on his chin. He developed redness on his mouth and on the cheeks, and he started itching. We stopped the challenge. He was otherwise fine, and the rash faded, and he remained active and playful. And here you can see his picture with the rash on his mouth, his father holding him, and the medical student who we are teaching about food challenges standing there watching. And this is a close-up showing the little drop of milk that caused the problem. Here's another patient who has history of previous frequent ingestions without reactions, but then at some point she was tested because she was tested to environmental allergens. Then somebody did a panel of food allergens, and lo and behold, there's lots of positive tests, particularly to peanuts. So when she came to us, she had avoided all 3 nuts and peanuts. Her presumed reaction to peanut was a small pimple-sized rash when peanut butter touched her face. But before that, she had eaten peanuts just fine. And that presumed reaction happened after she had seen the tests. So we did an open challenge, but she immediately complained of throat itching and was very anxious. So we had to stop the challenge, although we felt that the reaction was just anxiety. And then we ended up with a placebo-controlled challenge, which means neither the doctor nor the patient knows what is being served, and it gets conducted on 2 different days. One day you would have the peanut hidden in some food that they can't taste, and another day they would have the same food but no peanut in it. So eventually she took half a teaspoon of peanut flour in applesauce and cinnamon and had no signs of reaction. And here you can see her. She turned to be a fundraiser for food allergies. She did some projects selling these friendship bracelets and raised money for the Food Allergy Center. And you can see her happy mother and, of course, her happy doctor as well. So what about a patient who may have had a reaction to a food that may have contained peanuts? This patient had a history of breaking out in a rash after eating a candy that was not supposed to contain peanut, and they thought it was cross-contaminated, and has a history of unexplained hives. Her tests to peanut were negative, and a previous one was very low positive. The last skin test to peanut was very small and clinically not significant. So we went on to do a challenge. She took 2 teaspoons and almost up to the 3 teaspoons of peanut butter, which is about a serving of peanut butter. She was fine until we noted that her eye, her conjunctiva became itchy, and she was itching it and red. And as you can see here, that the white of her eye is swollen and red, and of course, very itchy. So she was given Benadryl and was monitored in clinic. The eye itching resolved. She was fine, clinically asymptomatic and very cooperative. But we noted that her blood pressure was changing from baseline to a higher number. Here's another patient that the mother brought the picture of a pea reaction at about 13 months of age. You can see the redness on the lips and on the face after eating these peas. The star of Desperate Housewives comes and asks, can he have soy? I asked, well, how did he do with peanuts? And you can see that with peanuts, he also had swelling of his lips. So that's a food challenge that resulted in swelling of the lips, and we knew that he was allergic to peanuts and peas. But what did we do? We followed him for what I would call several seasons. And up to the fourth season, his peanut test was really low, to where we did a challenge to both peanuts and peas, and he did not have a reaction. You ask me what age is a food challenge done in, and I can tell you that we do it at any age, but the most common when we look at the food challenges we do is at the younger age group, which is the harder because you have to interpret the behavior, but it takes somebody who's experienced to be able to interpret that. Anyway, it's usually when the kids are going to either daycare or school, and this is when the parents want to do the food challenge to know if the kid really has an allergy. The other question is, what's the percent of positive food challengers? And actually the percent of positive food challenges, meaning a reaction, is rather low. It's about 30% for eggs and peanuts, maybe 44% to cow milk, but very low to soy and wheat, which are commonly thought as allergens, but they're not. We try to predict what will give, what will have a patient pass a food challenge, meaning being allergic. We looked at many factors in a publication we published last year in the World Allergy Journal, and we looked at gender, males versus females. We looked at socioeconomic status, and we looked at age. And the socioeconomic status was based on the insurance. And as a matter of fact, there was no good prediction of who is going to pass a challenge. So this is a summary of some photos from my clinic that adorn the cover of the Journal of Allergy and Clinical Immunology Oral Food Challenge Manual that the committee of the Academy had put together years ago to help allergists perform the procedure. And they were all little children, but I want to show you this video of this young adult who was going through a food challenge, through a research study, and this is double-blind, placebo-controlled, and you can see obviously that day he got the peanuts because he's itching like crazy. And you might say, well, he's just itching, even though it's extensive and is very uncomfortable. But that itching was followed after that with him becoming lightheaded, almost fainting. He had to be given epinephrine and had to be receive fluids and sent to the emergency room. So food challenges can result in more serious reactions than just the skin reactions. So a challenge needs a challenger. There's the Dodge Challenger, there is the Harry Potter Challenger, and then there is the Faith Challenge, which is this competition that FAIR has to develop an innovative and more compassionate food allergy diagnosis form. So what is the deal? I just showed you that OFCs are problematic for patients. They don't like to have them done, even though they may be helpful. And so to get SOS for the patients, the FAIR has made this Faith Challenge. The first part of all that is trying to establish infrastructure for the research in food allergy. And the infrastructure that FAIR was visionary enough to develop is to develop a biobank for food allergy. And I'm going to tell you a little bit about the biobank. So a biobank is a biorepository that accepts and processes and stores and distributes what we call biospecimens, meaning it could be blood, it could be skin swabs, it could be any part of a human body, like urine or a swab from the mouth, for example, or stools. All of that can be a biospecimen that gets stored in a biobank. Biobanks were initially very small, university-based. Then the government actually started developing biorepositories for research, and eventually some commercial companies got in the market. And there is now population-based research and the biobanks, and there's some virtual biobanks as well. The data also progressed from being just basic data about when the sample was collected to extensive information about what the patient phenotype is, and also now some biobanks extend that into genetics, proteomics, and other omics information. The FAIR Biobank is a disease-specific biobank, meaning it's concentrated on patients with food allergy. It's going to provide tactical and logistical services for management of food allergy-related biospecimens and data, and establish guidance on biospecimen collection and handling. It's going to work closely with FAIR Data Commons, which is another infrastructure that FAIR has developed to ensure linkage to other critical data elements, such as the medical history, treatment, and outcomes. So our Cincinnati Children's Hospital Discover Together Biobank was lucky to be awarded a grant from FAIR to become the biobank for the FAIR clinical network. Our biobank, Discover Together, was founded in 2007. It has samples and data and infrastructure to support institutional research and external customers as well. It houses about 1.2 million samples and related data over 160,000 patients. And it provides infrastructure for investigator-generated research. The Discover Together Biobank has many initiatives. One is called Discover Together. One is Better Outcomes for Children, where DNA and genetics is collected from patients. And then genomic control cohort is a very important part, because once you have a disease, you want to compare all the data you got with data that is for normals who don't have a disease. So we already have 1,000 control sample populations from Cincinnati. The Discover Together Biobank supports national research networks, as you can see here. For example, the March of Dying Prematurity Research, the Down Syndrome Achieves, and the Electronic Medical Record and Genomics Network called Emerge. The purpose of the FAIR Biobank is, as a discovery center as well, is to identify disease-specific biomarkers and their significance in diagnosis, prevention, and treatment, and collaborate with all the food allergy network, which are known as FCNs, and non-FCN sites and FAIR partners for food allergy-specific biomarker discovery and clinical research. This is a diagram of how all this interact. So here are the FAIR members who sign up to be members of FAIR. They form the patient registry, which interacts with the data commons. And these are the clinical research centers, the clinical care centers, and discovery centers, all part of the FCNs of FAIR. And they all work together with the data coordinating center, which is housed in CHOP, and the Biobank and Biomarker Discovery Center, which is housed at Cincinnati Children's. All this structure aims to have groundbreaking research and innovation. So FAIR has set responsibilities for the Biobank to advance public knowledge of the pathophysiology of food allergy and the identification of improved diagnostics and prognostic markers of disease. It has really given the Biobank many responsibilities, implementation and pursuit of key biomarker data generation, provide data storage, and lead training of other centers who don't have yet the knowledge or infrastructure to improve the biomarker research, and establish data sharing infrastructure as well. The Biobank and Data Center will also support design, piloting, mechanistic studies, develop protocols, support data management, and store all the samples that will be collected from various centers. It will also help generate monetary support from the FAIR centers, for the FAIR centers, for the conduct of mechanistic studies through funding from NIH and philanthropy and other pharmaceutical companies. It will also support extramural applications to fund the work that's the infrastructure for the research in food allergy. So I compare OFCs to high waves or food challenge to high waves and FCs. SOS is coming, so help is coming, and help, I call it save our samples. And here's the help coming, and eventually there is the calm seas, and we have faith in it by developing biospecimens and biomarkers. And here's the summary of what the phase challenge is. It's a 3-pound multi-million-dollar competition to replace the old food challenges and create a new gold standard for diagnosing food allergy and assessing treated food allergens thresholds, eliminating one of the biggest barriers to care. The phase challenge will attract the best minds to develop and employ innovative technologies that will lead to a simple diagnostic test for food allergy. And this is what we are all looking forward to. And I thank you for your attention.